Hello and welcome to Pain Unfiltered, where we go in-depth into the interventional pain and spine world with some of the top key opinion leaders and executives in the space. We are your hosts, Dr. Patrick Buchanan and Dr. Timothy Deere for this Aspen podcast. Let's get started.
You know, Patrick, I'm doing fantastic. It's great to see you and our friends, and I look forward to this discussion.
Yeah, that's great. We're basically just a couple weeks out of the annual conference, so we're all fired up for that too. Get to see each other, talk about great therapies, and have a good time. So fired up about that. We'd like to announce our fifth sponsor of the season 2, Spinal Simplicity. So they've actually added an SI fusion device to their portfolio, and we'll be discussing a little bit about that in the next episode, as well as working up SI joint pain, which I think is essential for this therapy, patient selection, as well as the different kind of techniques in terms of lateral fusion, posterior fusion, lateral oblique, and a lot of the stuff. Tim, can you just share some of your thoughts on that?
No, I think it's an exciting time. You know, we have a posterior approach, which is very minimal, and it's done quite well for a lot of patients. We have a lateral oblique approach, which I've done in many patients quite successfully. And now we have a lateral approach that's less invasive than other lateral approaches, which is one screw versus multiple above S1. So it lowers the risk of gluteal artery or nerve injury. So I think, it's just another evolution. We've got now, in my opinion, 3 great options: posterior with the bone allograft, lateral oblique, which is certainly more superior and takes away some of the risk, and now a lateral approach that's using a opening mechanism, which will give you more stability. So I think it's just another evolution of safety and efficacy. So we're excited to see how that goes, and getting ready to integrate that into our practice over the next few weeks.
Yeah, there's definitely an exciting time to be in the SI joint space with all these therapies coming, and exciting to see what the data shows as well for these long terms. We would also like to thank Mainstay Medical, Saluda Medical, Nalu Medical, and Medtronic for also sponsoring this season as well. Today, Tim, we're going to be talking about, I think, a really important topic today, closed loop stimulation. And we have 2 great guests on that are experts in this therapy. We have Dr. Krishnan Chakravarthy, Aspen President-elect, and Dr. Nomen Azeem, Aspen Vice President of Membership. Thank you guys for joining us.
Thanks guys.
Thank you.
So why don't you guys just introduce yourself briefly and just give a little bit of background on your training.
Sure. You want to go first, Nomen?
Sure. Yeah. So Nomen Azeem, from the Washington, D.C. area, Northern Virginia. I'm trained in physical medicine and rehab, trained up at Georgetown. From there, went on to do an ACGME pain fellowship up at Temple with the late Dr. Frank Falco. Went from there to NOLA, had my first job at a pain practice out there, which was phenomenal, great experience. From there, joined an orthopedic group in Sarasota. So completely different from working in a pain practice, but it was a very, very good experience. I learned a lot. And then about 7 years ago, started Florida Spine and Pain Specialist down in the Tampa, Florida area. And 7 years later, we have 4 office locations, a surgery center, private academic practice, doing a lot of research out of the practice. Just hired a new physician partner, Dr. Ali Kasamali. And we're looking at starting a new Florida Spine and Pain Specialist Interventional Spine Fellowship to start July 2025.
Great.
Yeah. So, hey, everybody. I was surprised that Patrick went after my entire first name. Usually everyone just shortens to Krish, and he did the whole Krishnan, which is awesome. So it actually comes from South India, so I'm pretty impressed that he got that whole thing down. Been a actual guest on this podcast. Love listening to it. My own background, I actually trained all on the East Coast. I did my residency at Hopkins and did my fellowship at Mass General, and then went over to UCSD as a faculty. I was there for about 6 years and decided that I would try other things with my life outside of academics, and have been kind of between practices, but now I've got a fairly large practice with a lot of physicians that have kind of joined and have a surgery center out in Southern California, and been still very active in training fellows. So I've been very fortunate to be able to do that, and just really excited about the annual conference. I mean, I think, as Tim was saying, such an amazing time to be in pain medicine. I just think that, there's just such a wonderful amount of new therapies out there. So it's just great to be able to join you guys today.
Thanks, Chris. I've had a lot of practice with your name over the years. Obviously, we've known each other for a while, so appreciate the camaraderie and friendship. But let's start off with you. Can you kind of give a general overview of closed loop stimulation, what it is technically? I mean, you have a great background for this, and kind of explain to our listeners exactly what that therapy is.
Yeah, no, I look, I think for me kind of bringing kind of a little history to this, if you think about the span of 60 plus years, I kind of have, I think, segues to what I think are important landmarks in neurostimulation, right? So you had in the late 60s, you had the whole idea of gate control theory, and someone was the first attempt at doing some form of epidural stimulation in a cancer pain patient. And then you had the big process study that was done by Dr. Kumar out in Canada that really showed paresthesia-based stimulation was important for pain control. And then Tim himself was really a big part of some of the more what we call non-paresthesia-based stimulation, whether that was high frequency that Dr. Caporal published or Dr. Deere put out there in terms of looking at burst DR. And really I think when you think about each of these segments, what we have come to this realization is that you can develop new waveforms, which is, my concept of what you're delivering to the spinal cord. But really, to me, closed loop is an entirely different way of how you're delivering that stimulation. And I think that, the best analogy that you could give is you look at the cardiac and diabetes space. I mean, they revolutionized how therapy was driven with CGM or continuous glucose monitoring, right? It changed the entire paradigm around why does a physician understand what therapy they're delivering and how consistent that dosing is. So I think every science like neuromodulation has a pre and post moment. I think closed loop is something that's going to be important. It's a topic of conversation that is going to have every company thinking about how they're going to incorporate that type of stimulation model in whatever waveform they're delivering. But I think it's such an important part of understanding the language that is neuromodulation that it's going to be a part of that conversation in the next 5, 10, 15 years. I mean, how can you ever imagine stimulating blindly, right? I mean, there is something really powerful about getting physiologic data back to determine the dose that you're delivering. So I think the context is really important. I think it's important to say that this is something I think every physician practicing neuromodulation should have an understanding about.
No, that's a great, I think a great introduction to the topic, Chris. I think, basically, we know that there's 2 companies that have closed loop. There's 5 that don't, if you want to count 7 companies in the spinal cord stimulation space. So Nomen, I know, we're familiar with some data from the Evoke study, Avalon study, which is a one mechanism. Now you have a new device that you and Krishnan just launched in the US. That's a different form of closed loop. What's the studies going on right now with the Medtronic closed loop system? What's going on with that, and how are those studies looking? When do we expect to see the published data on those?
That's a great question. So, there's a few ongoing studies. There's going to be a post-market study that we're going to be looking at, everything from PROMIS 29, pain scores, ODIs, things like that. There's a study that was done in Australia, which did show very good efficacy 6 months out, as well as, responder rates that were equivalent or better than the DTM studies that we have previously. So, there's a lot of data that's there, but there needs to be more that's collected. One of the things that I love about this therapy, though, and again, as you mentioned, there is another company that has done this already. But closed loop is so important from the patient experience side. When you have a patient that wants to be active, when I start talking to patients about spinal cord stimulation and how I want them to be not just pain-free or have their pain improved, but I also want them to be more functional. In the Gulf Coast of Florida, we see this day in, day out. You've been to Florida plenty of times. I mean, people want to be out in the sunshine. They want to play golf. They want to play pickleball. They want to, exercise. They want to, a lot of them play with their grandkids or take them to an amusement park. And a lot of times with these patients patients that have stimulators in, the different postural effects of what happens to the stimulation, whether it's under or over stimulation, can really impact how they're utilizing their stimulator. Some of them will turn it down, some of them will turn it completely off, and so it's really an unmet need. I can absolutely say in the Gulf Coast of Florida, I've had patients that we did an SI joint fusion for that became more functional after a different type of system that somebody else implanted, and they became more functional and come back and say, hey, well, look, this is great, I'm more functional, but man, this stimulator that I have in, I get these zingers and I have to turn it off. So again, absolutely unmet need. I think that, I'm very, very happy that, we have more than one player in the market. And honestly, I think where we're going for neuromodulation and in our space, we really want that patient experience to be optimized as much as possible. One, because of the fact that we want them to be more functional after the pain is relieved. But beyond that, we really need to look at the patient experience, optimizing that, and also keep in the back of our minds explant data. The more that we can optimize this and get good longer term relief, that's how much our explant data is going to improve.
Yeah, really
I think that's a huge point, Nomen, is the explant data. Keeping this in that therapeutic window or that therapeutic dose and constantly adjusting the dose to this. So I think that's huge. Chris, I'll get to you with the next question. I think closed loop, like you summarized well, you're delivering a stimulation, you're capturing it on the other end, and then in real time, you're recalibrating that and fixing the dose. Can you talk about just a little more technically in terms of kind of the filters that, Medtronic is using in terms of, are you getting real-time feedback? Are you adjusting every single time? And then kind of the frequencies too they're using.
Yeah, so great question. So, okay, the starting point is having some basic facts, right? So what happens is that at low frequencies, you can measure an ECAP, right? So if you keep increasing the frequency 50 hertz, 100 hertz, 1,000 hertz, at some point you're pinging the cord with such a high frequency, you cannot capture an evoked compound action potential. So starting with basics, what is an evoked compound action potential? So you have all these different cells in the spinal cord, you send a current, and those cells, when they're activated, they send some kind of measurable neurophysiologic activation based on these ions. You're capturing that. The challenge is, and this is where the subtleties of the differences in the approach to two very different companies that are offering closed loop is, we have recognized there are 7 companies out there. And some companies have waveforms that are just traditionally at a low frequency to mixed frequency signals that are at higher frequency. So if you look at HF10, that's at 10,000 hertz, you're not going to be able to capture any kind of ECAP because it's pinging the cord at such a high rate that you can't actually get something discernible. So when you look at that, the concept was, how do you create filters when, if you're trying to measure something like an ECAP, are you measuring an artifact or are you actually measuring an ECAP? And some people use a template. Other people are using these different filters to actually validate the fidelity of that signal, right? So what essentially happens is when you look at DTM, which is differential target multiplex, you have a mixed frequency of 50 hertz to 1200 hertz, and you're putting those two segments together. And the reason and the rationale for that was, when you look at 90% of what makes up your cell type in the spinal cord, it's not neurons, they're glial cells. So the basic idea is that mixed frequencies, they become more anti-inflammatory if you believe inflammation is bad for the body constantly. So to create a effective system that can close loop around that, you have to be able to capture that ECAP at that 50 hertz and then loop it every time you're getting that low hertz frequency signal while you're delivering a mixed frequency, right? Because when you run DTM, you're running a mixed frequency signal between 50 and 1200 hertz. So you're running the dipoles down the actual 2 electrodes. So what that means is that you're still measuring ECAPs constantly, but you have to have multiple filters to be able to tell when you're in the low pass to high pass, base or prime signal. So why that matters is I think as clinicians, there's certain things that I think we need to say, right? There's some factual things. You're measuring ECAPs, absolutely. You are able to measure ECAPs and deliver something that has more than just traditional, what we say, quote unquote, tonic stimulation. To be able to do that, you have to have different filters that allow the device to be able to pick up an ECAP at that low frequency and still loop it in this kind of mixed frequency therapy. So when you are looking at optimizing something, the clinical data supports the therapy, and then you need the closed loop to make sure that you're able to support those options for patients. So that's the thought process. There isn't any, I would say that the battery in itself, the complexity of it is in the chips. That's what makes the ability for you to be able to do a mixed frequency signal. But if you run only high frequency, you cannot close loop. There's a limit to that. You can't measure something detectable. So you need to have a low frequency component to be able to do that.
So, I want to follow up that question to Nomen. Krishnan, great explanation as always, and certainly very scientific. Now I want to get to the common doctor like myself, and I'm going to go to Nomen to help me with that, because that was extremely great answer. President-elect of Aspen, wonderful answer, but too complicated for me in a little bit of way. So Nomen, let's get this down to brass tacks here. So tell me why, because I think Chris just gave a great explanation that you have to be able to get the ECAP to use the closed loop. So tell me, right. Two things I have in my mind right now. There are some waveforms where there won't be an ECAP, and I think that was shown by Fulowski in some previous intraoperative neuromonitoring studies, right? So it's closed loop just out for those types of waveforms, number one, going forward, and two is, what percentage of devices in 5 years do you think will have some closed loop component? Will it be all devices in spinal cord stimulation? Will it be the current two companies where we see evolution here? Or is this a passing fad? Well, what's going to happen to the therapy? So will all waveforms be able to do it eventually, or are we going to see a passing fad going forward?
That's a great question.
Right. Yeah, those are actually very great questions. So, as far as the first question goes, I do agree with you. I think that if we're not able to capture an ECAP in those situations, then obviously you need that in order to be able to utilize closed loop. So that is something that we need to continue working on and get better answers for. As far as where the field is going, I love that. I agree 100%. As I mentioned, I think that when we're talking about payers and what they're looking at in terms of longevity and how long these stimulators are lasting, I practiced long enough where it was just tonic, right? And we've flourished and we've gone so much further than just that. We do have these wonderful waveforms. We do have so many different features in these devices now. I think that closed loop is very, very important. And I do think that in terms of that patient experience following the implant, I think it's crucial. Again, when I tell a patient that, I'm doing this so that you can be, improve your pain, but also be functional. The amount of data that we have, I want to say there was a survey done recently looking at patients. I think there's 100 patients post-market survey on patients that had all the devices across the board and that did not have closed loop, and the amount of patients that I think it was more than 50% of patients end up turning their device down, when they're exercising or taking certain postures, and I think 15% even turn it off completely. We're all of us, we're not putting these devices in for patients to turn them off, and it's a real impedance in their lifestyle. I always tell patients when primary cell batteries became, the big end thing, I switched over a lot of my patients to primary cell because out of sight, out of mind. You go live your life, enjoy your life, let the therapy do what it's supposed to do. Same mentality with this in my mind. It's the exact same thing. It's, we want our stimulators to be able to adjust without your input so that you can go live your life.
I just want to ask a follow-up question to Krishnan real quickly. Nomen, great answer. I agree with everything you said. So Krishnan, will there be a time where we'll be able to, on the table, predict responders with this type of system? Is there going to be that type of, predictor responder, whatever system we're using? Do you think that would be the next step in this evolution of closed loop?
Absolutely. And you're 100% spot on, because I think what you're getting at, Tim, is imagine you're basically creating a real-time biomarker, right? So if there's a pattern that shows durable data with specific patients, you can capture that early. It's a hard debate because, our friend Sam Eldabi would tell you, well, what is a trial? Out in Europe, they're talking about completely getting rid of trials and saying everybody should be having an implant because there's no predictability. But I think what predictions about who is and isn't going to be a responder. And I think that, big data plays a big part into this. The more you collect, the more population data you have with spinal cord stimulators, I think it's really impactful. And I think it's totally open to where that would go. I think an important point.
Yeah, speaking of trialing, Krish, why can't Medtronic with their Inceptiv trial patients in closed loop right now? I believe, and correct me if I'm wrong, you can only do it after the implant. And is there going to be a shift in that? Are we going to be able to trial patients in closed loop in the future?
I think the question is that, why in some ways, my thought process is, again, it goes back to what's the function of a trial, right? Is a trial a way for you to determine what response to different therapies are they having? And then therefore you're optimizing how that therapy is delivered after. I think anything could be developed to make something functional during the trial. I think the question really becomes, and this goes back to my point, if the conclusion from the neuromodulation community is that trials by themselves have no predictors for how somebody responds, then I think the better question, and I'll tell you where I would love to see this in the next 5 years, is finding outcomes that change clinical adoption. And that's the challenge, right? Because at some point, Nomen and I are saying, hey, this is a landmark moment. Why isn't everybody doing closed loop? But yet there may be a lot of clinicians out there who say, hey, I'm getting great outcomes at the 5 other companies. So the thing is, innovation's great. You can keep innovating the hardware. You can innovate all of the ways you're delivering, but nobody actually focuses on, well, VAS scores are still very primitive. Someone's giving you a subjective answer on a day-to-day basis and you can't even measure that stuff. So I think to Tim's point, if I knew that a trial was giving me some data about who's going to be a long-term responder, then I find it of value. Otherwise, I'm going to look at trialing a bunch of different things, and I'm not necessarily certain that, a period of 3 to 5 days is going to be a great reflection of inconsistent dosing. You see what I'm saying? It's very granular. I think we look at trial data and you say 50%, 60% improvement. But I'd like to see more data on that. I don't know if Tim wants to comment on it, but I don't know if the community itself feels the trials are that good a predictor at this point.
Yeah, I want to comment on that. Great discussion. So Sam Eldabi is a friend of mine, but I think that the dream that there'll be no trials in Europe is not going to happen. In fact, in Australia, we may not even see stimulation anymore because of failures, right? So, I think that is not going to occur. So we do need to have a trial. The question is, what are we trialing? And I think, Chris, you bring up a great point. VAS scores have been notoriously poor. NRS scores are notoriously poor. So I think what we're going to go to eventually is going to be some biomarker, whether that be with closed loop, which we have, both, Medtronic and Saluda have closed loop to be able to tell us what the ECAP looks like, whether it be some mechanism through the burst waveform or other waveforms that tells us who's a responder. But we just have to find new. That goes back to PhD work with physicians, collaboration to find that biomarker. But I think there will always be a trial because I just know the payers pretty well. And I think the trial may need to be a certain length of time, but there's going to be other markers. And my goal is to get to a point where we can be looking for a biomarker, whatever that may be, that gives us a better answer than the pain score. And I think you mentioned that, and I think that's where we're going to evolve to. But that's going to take a lot of money, a lot of research. And we've seen the neuromodulation market be flat the last 5 years. Yeah. And I think it's been flat because we can't predict sometimes long-term outcomes. We've gotten better at it, right? We've gone from 50% to 80% in most studies. Our practice, we have medical students, we have about 87% long-term implant 5 years down the road. But I think that's not the national experience. It's probably still around 60%. So I think so. I guess, Nomen, I'm going to bring this back to a question. I know we're getting a little bit near the end of our discussion, but the question is, at the very beginning, Krishnan gave a great history of neuromodulation, went through my friend Chris Kumar's work and others' work. But, do we need large prospective randomized studies of every company coming along with new innovation? Do we need that? Because I asked you in the beginning, Nomen, what was the studies that are out there now? Do we need to create level 1 data now to show this is a difference than DTM by itself, for example? Do we need to have comparative data against CMM? What's your thoughts on that?
No, I think the more data, the better. And I agree, big data is going to be the key moving forward. So, I think that there's always going to be a need for us to be able to substantiate what we're doing to the payers, because we don't want to lose the ability to do what we do every day and provide such great relief to our patients. So I think that there's a need for that, across the board. And I, to your point, 100%, there has to be every vendor, we have to figure this thing out collectively as a space where, you asked me earlier about, do I see closed loop, the other companies kind of also buying into this and kind of incorporating it. I think that should happen. I think that, things like MRI capability needs to improve. I think that's a huge issue right now. I know in my practice, I've explanted quite a few patients that needed MRIs, breast MRIs. And so it really, again, I think that more data, I think RCTs absolutely. And, I'm looking forward to even what's down the pike right now. I mean, more technology and again, making sure that we're getting the best long-term outcomes.
Yeah, I agree with that. Also, I think real world data is going to be huge and important moving forward as well for not only patient outcomes, but for payers too, to look at this. So we've kind of had a disconnect in some of the studies lately, to be quite honest, and I think we need more real world data, which kind of leads me to my last question for both of you. What are your personal experiences with Inceptiv and closed loop in your own patients right now?
Great. I want to piggyback on what Patrick said. I have a theory why the real world data isn't as good as RCTs, and it's because people aren't as disciplined in the real world in terms of patient identification that you get in a study, right? So the truth is, I think a lot of this, and I think Tim would share this, right now, Aspen as a society has an incredibly immense responsibility because we are seeing innovation in the pain space exploding, but education isn't catching up. People are still trying to figure out in an ACGME 1-year fellowship how to catch up to all the different nuances. They're trying to put the lead in the right place, let alone figuring out what's open loop versus closed loop. So I think payers would love to say, hey, do more studies. We have like 35 RCTs. Spinal cord stim works. We're spending a lot of money doing a bunch of studies. We need to get education and outcomes and put more money into things that are getting the younger generation trained. Because if I go to Tim's practice, his real world data is going to be far different than a brand new beginner spinal cord stimulator guy who's going to say, hey, I don't know if I picked the right patient, right? So I think there's an important part in making sure we're framing this discussion, because I think it really should emphasize education is a really important next step for us. I think there's a big disparity there, and I'd love for Aspen to be doing that and taking the lead as it already has. Part of that real world experience, Inceptiv has been around for about, I think, roughly 2-3 weeks. In fact, we were the first center to put it into the country in the US. We had a really nice DPN patient that had traditional kind of peripheral neuropathy. What I loved about is as waveforms become a commodity, hardware becomes an issue, right? MRI compatibility, size of the hardware, the lead fabrication, all of that. But the other part is the interface that you have with a lot of these patients. So when we were testing all the open loop to closed loop, we would literally move the patient in different positions, and you can get all of these zingers elicited. What's really interesting is half the times you don't even ask about that stuff, right? Because you're so comfortable with your rep doing all of the management. So what I found myself doing was I was really trying to explore what the differences would be between open loop to closed loop, and you can see clear differences. Now, some people may say that's not a big part for my patient practice. Like, hey, they don't complain about all of these things. But I think the point is that as we're trying to do more and more cases, and we're doing a couple cervical cases coming up, I think there's a lot of value to seeing it. But you have to ask. I think you have to ask these things that are important to patients. It's not a direct thing that I would say is a out and about in terms of making you think that this is important to practice per se.
And
Yeah,
Nomen,
I
how
would
about
say
you?
that I had a similar experience as well, with spending a lot more time with the patient and my clinical team, and having them kind of, bend, twist, raise their arms above their heads, arch their back. And we were able to, eliminate all those, quote unquote zingers with the patient. And we've seen the patient back for 2-week follow-up. And I want to say, yeah, they're coming back for a 4-week follow-up next week. And thus far, any feedback that we've gotten from the patient is that he is able to do everything. And same type of patient, actually, ironically enough, it was a DPN patient who actually lives by himself, older gentleman, lives by himself, and has to do a lot of maintenance around his home, yard, whatever, by himself. So he's going to be taking all kinds of postures that may have previously caused some issues with him having to adjust. And even at the 2-week follow-up, when I saw him, he said, "Hey, I'm not touching this thing. It's working."
I want to finish with just a closing thought from me, and then I think we'll have just a brief closing thought from both of you, and then have Patrick give us a final word. My closing thought is I think we're missing the ball a little bit in this discussion, and so I want to make sure I come back to what I think is an important point we haven't talked about yet. I don't think it's zingers, because there is waveforms out there that don't produce a zinger. In fact, the most common waveform I personally use is that we don't have any paresthesia most of the time at all. So it's not a zinger issue. I think the real issue of closed loop and whether or not it's going to be valuable or not for whichever company it may be. We're discussing Medtronic's new product tonight, and certainly we have Solido on the market with closed loop, but it's going to come down to the delivered dose of electricity. And I think the delivered dose is more important than the paresthesia. And I think that's what we're going to really focus on going forward in research. I think, as we look at the data analysis, does it matter if we can measure the dose of delivered energy? And that's what closed loop gives us a potential value offering of. And there may be waveforms where it doesn't matter. And there may be waveforms where it matters a lot. And I think what we got to figure out, the four of us as part of Aspen will be part of that solution, figuring out when does it matter? And if it does matter, what is that dose? And if we know the dose, we can have the device then using closed loop control the dose. And if the dose doesn't really matter with some waveforms, that may show as well. And I think that's where we're going to come to. So I like everything both of you said about the comfort and moving the patient, all those things. But I do think the delivered dose is the evolution of closed loop and really where I think we're going to talk about. So hope to have you both on the podcast again, maybe in 12 months, and maybe we'll have more long-term data and look more at, the delivered dose matter, because that really may lower the energy needs, the battery requirements, the battery size, the battery recharging, all those things that we talk about. And that could be the real revolution that leads to more salvage. No, I'm going to go back to your original point of explants. That may lower the explant number. So I am excited about everything you both said. I think it was quite fantastic. And have you both give us a closing thought, and then have Patrick finish this out here.
I'll go ahead. So, this was phenomenal. And I want to thank both of you for having both Krish and myself on. Again, these are the types of discussions that we're going to look back at years later and say, Tim, your points are phenomenal. I agree with you 100%. I do worry about payers a lot with our patients, and, with a lot of other therapies that we have in our tool belt now that we didn't have, say, 10 years ago, everything's under attack. And I don't want neuromodulation to be one of those things. So the more data that we secure and the more that we focus on that patient experience, so that they're not wanting an explant and coming back years later saying, "Hey, this thing never worked for me." I think that's where we need to be as a field, and there's a lot of different options out there right now. And I think, again, it's not a one size fits all. So whether it's a paresthesia free, type of waveform, or something that may not even need closed loop, like you said. I'm just very excited for our space, and I'm glad that we're having these conversations. And Patrick, you brought up something that I thought is imperative: is RCTs are great, but we really have to substantiate those RCTs with as much real world data that we can get. So I look forward to more such discussions at our Aspen Miami meeting coming up. In fact, Krish and I will have a lunch symposium discussing this closed loop for Medtronic on Saturday. And so we hope to see everyone there.
Awesome. Love that.
So I have an interesting point to piggyback on what Tim said, but I actually think the challenge that you're posing is one, I think, a very important question. You're asking, well, how do I know when closed loop is going to be relevant? What advice as a clinician would I tell the 5 other companies? Hey, you have a waveform that has good data. You think it's durable. Why should I? Their question would be, Dr. Deer, why should I implement this? Why should I spend millions of dollars developing a closed loop system because 2 other companies have done that? But this is what I find to be, and I'm surprised that our industry partners haven't done this, but this is the only specialty where we don't have a standardized way to build a therapy. Nobody talks about preclinical data on the same outcomes. Nobody talks about clinical data on the same outcomes. So till we discipline to say, these are the outcomes that matter, and you're going to standardize across different randomized controlled trials, the problem that comes is that it's like an open-ended answer. No one will have any idea. Because the flip side is, to the credit of our friends at Saluda, they were the only ones with a 3-year RCT that showed such a high responder rate in compliance. So if you say durability is measuring it out to 3 years, and we set that as a standard, then any of the folks that are not doing that, unless they produce 3-year data, then you would say, well, what does that durability mean? Like, you don't have data to support durability. It's an extension of assuming a 1 or 2 year data point is going to extend out there. So I think if we have to have meaningful conversations and then say people are investing good money into developing new innovation and answering, I think, really profound questions that you're asking, Tim, which is, I think it's a really important one. We have to standardize outcomes. I mean, otherwise it's just you can't come to any conclusions on this. So I do think that there is a real value to this discussion. I really am hoping that this is a call to changing the way we innovate, because it's not just the payers. I think even big companies will start to feel like, why am I putting time into innovating if I can't see clinical adoption from that? And it's not meaningful enough. So I think that discussion should we start to think about this differently altogether?
Thanks, Chris and Nomen and Tim, for this great conversation. We could go on for hours and hours on all these different topics and tangents, but it's been a real pleasure having you guys on. Like Tim said, we would love to have you guys back on next season to talk about this in further depth, to see where we are in just a year. You know, a lot can happen, right? But I just want to thank you, Chris, for, you did a great job describing closed loop, broke it down technically, and kind of what the advantages are for that. Nomen, you kept it real with all the, your experiences and what this means for the future for both our patients and for payers as well. And Tim, thanks again. You brought up some great points as well for it. Are other companies going to be adopting this? And I think they are going to. I think whether it's in a different kind of waveform, trying to find an objective data for that, doesn't have to be kneecap. Maybe it's something else that they can objectively identify. So it's going to be interesting to see in the next 5 years where this space goes, because I agree. I think capturing objective data on the cord is the way to go to get that prescribed dose to consistently get, long-term outcomes for this. And lastly, I just want to congratulate Medtronic on this. They found, this is the way to go to find objective measurements. They put the time and the resources into it. So congratulations to them, and looking forward to what this, bodes for the future. So thank you all again for joining us, and looking forward to seeing everyone at the meeting. Thanks, guys.
Bye-bye. Thanks, guys.
Okay.